This morning, as we begin our interim meeting, we stand in the midst of very challenging times. In our nation's capital, debt reduction talks have failed. In divorce court, they call this irreconcilable differences. In Washington, it's called politics. Medicare fees are scheduled to be cut 27% at the end of this month. However, the conventional wisdom is that Congress will put together, yet again, another temporary freeze before then, avoiding this issue until after the next election. Politics. In Massachusetts, there's consolidation and integration happening everywhere, from the left part to the right part of the state and everywhere in between. Hospitals are coming together, physician practices are coming together. Better clinical integration is going to be a very good thing. But this will uproot some of our colleagues and change how they make their living. Meanwhile, the business community, local governments, and state government are struggling to pay their health care bills. They're demanding that we cut health care costs, or they will make the cuts for us. About a month ago, at our annual State of the State conference, Susan Denzer, the editor of Health Affairs, predicted that hospitals soon will have to learn to live on Medicare fees. You could debate about whether she'll be proven right or proven wrong, but I think she's got the spirit right. Times are changing, and it's happening very, very quickly. How did we get to this point in time, and what can we do about it? That's what I'll spend the next few minutes talking about with you. But first, let's see where we're going. Let's go back a few years. We're going to get in a time machine and go back a few years. Do I do that? You do that? Okay. So, there we are. You may remember this scene. April 2006. The governor, Senator Ted Kennedy, the leaders of the Massachusetts legislature gathering at Faneuil Hall to sign our epic health care reform law. That day was brimming with hope. We established a goal: provide health coverage to as many people in Massachusetts as possible. By any measure, it was a tremendous success. More than 400,000 people have insurance today that didn't have it on that morning 5 years ago. And today, less than 3% of our population is uninsured, exceeding even the most optimistic objections. But, you knew there was a but. But, we left one important issue unaddressed: the cost of care. It was a deliberate decision, a conscious choice made by everyone involved. Let's address access first, then let's deal with costs. This is what we have left for later: the relentless rise in the cost of health care, while the rest of the economy rose at a much slower rate, if it rose at all. If you've been to any presentation that Alice, Mario, Bruce, or I have given over the past 3 years, you've seen this slide before. We always show this slide. I am sick of showing this slide. But we can never forget that we do not live in a vacuum. Society at large gives us enormous rights and privileges as doctors. In turn, it behooves us to be respectful and sensitive to the pressures that society at large is dealing with. So today, there's a mandate to deal with the cost of health care. And by deal with, they usually mean cut. The days when we could work around the edges of these issues are long gone. Let's look at how state government has approached the problem and where we fit in. I mentioned Chapter 58 in 2006, expand access and then deal with the cost. 2 years later, in 2008, we got Chapter 305, a sprawling attempt to get a handle on health care costs. The Payment Reform Commission came out of that bill, the commission that Alice Coombs served on, which recommended a steady transition to global payments for almost everyone. We all remember that part of Chapter 305. What was less prominent in that was a section giving the Attorney General the authority to study trends in health care costs and use her subpoena power to get information that was previously unavailable. The result was a study that identified large differences in what hospital systems are paid, which could not be justified by differences in quality. Once that report came out in March of 2010, the political debate changed forever. A few months ago, we got Chapter 288. There were more cost control measures designed to help small businesses. It also created another commission to recommend what to do about these payment disparities. So now we come to this year. The great debate continues to be, how do we control healthcare costs? For some people in government, there's only one answer: rate setting. R-E-G-U-L-A-T-E, regulate. In other words, government decides what everyone will get paid. That was done with hospitals until the early 90s, and then abandoned, because there was a consensus that hospital rate setting didn't work. It caused distortions in the marketplace, and it stifled innovation. Because memories are short, that approach has regained favor, at least in some circles on Beacon Hill. Our approach from the beginning is that rate setting is not the way we should go. We believe that it would fail again, for the very same reasons that it failed 20 years ago. But we cannot say no and walk away, because if we walk away, we will get rate setting, no question about it. There's that old saying you hear time and time again: if you're not at the table, you're on the menu. And this is not an easy conversation. And we would be, believe me. So this isn't an easy conversation. No one likes to participate in reduction of your own income. But costs are coming out of healthcare one way or another. The only question is how and by how much. That's a conversation that we must be a part of. That's why Alice was an active participant in the Payment Reform Commission meetings. That's why we've been a part of many other commissions and task forces over the years. It seems to me that we go to a different commission or task force meeting every week. This is a partial list, and that's just this year. So we are definitely at the table. Now, what did we get out of this? This is a lot of time and a lot of effort on our part. Well, we got more than most people realized. In the payment reform bill, we asked for several things, but I'm going to highlight 4 things. Number 1, we asked to go slow and proceed carefully. Number 2, we told them that one size does not fit all. Not everyone can do this, and those who can make a transition are going to need a lot of support. Number 3, medical malpractice reform is critical to this. Without malpractice reform, physicians will not be on board. And number 4, administrative simplification. That's important too. Wasted time is just as damaging as wasted money. There's too much paperwork, too many prior authorization hoops, and too many processes that add no value. What did we get in the governor's payment reform bill? Almost everything. What will the legislature propose when its version of the bill is released next year? We hope next year, January, February maybe. From what we're hearing today, everything on that list will be in that bill. But there's one last issue to address, and that's rate control. In our view, the government does have a role to play, but not that role. In our view, the better role for government is to set the goal and hold everyone accountable for reaching that goal. Let the people on the front lines decide how to reach that goal and hold them accountable for reaching it. Can it work? I think it already is working. A couple of weeks ago, the Commonwealth Fund released a report showing that Massachusetts healthcare premiums are no longer the highest in the nation. Woohoo! 8 years ago, we had the highest premiums in the country. Now we're only number 9. Progress. It's progress. And since 2003, the rate of increase in Massachusetts has been strictly in the middle of the pack. The rate of increase in premiums has been right in the middle of the pack. There's 26 other states that have premiums rising faster than we do. Now, I don't want to minimize the burden of these increases on families and on businesses, but we could be doing something right, and it's wise to let us keep doing what we're doing. Does that let us off the hook? Definitely not, and it shouldn't. But it suggests that when we make something our objective, we can achieve it. So that brings us to my final point, the medical society's role in all of this. As I suggested earlier, we must stay at the table for all of these discussions. Everyone wants us there, and we are making a difference. But our presence at the table guarantees nothing by itself, and we can't make these difficult decisions go away. We have to address them directly and develop solutions that are balanced for everyone involved. If we help design the measures to hold ourselves accountable, if we work to protect the vital core of what makes healthcare special, if we continue to prepare our members for the changes that are coming, we will be doing what we're supposed to do, which is to promote a better healthcare system for everyone. I know we're up to the challenge, and I invite you to join us. Thank you, Mr. Speaker. That concludes my report.